Welcome to the deep dive. Imagine you're standing in the endoscopy suite. The tower lights are on, there's that familiar hum, equipment's ready. But here's the thing. The success of the whole procedure. It was probably decided in those crucial minutes before anyone even picked up the scope.
It's really interesting, isn't it? We often think of patient setup as just, ticking boxes. But drawing from Dr. Raju's YouTube videos, which are our main source today, it's less about checks and more like, well, precision choreography. Getting the patient positioned isn't just background stuff. It's absolutely critical for safety.
And not just the patient's safety, right? Also for the clinician's well-being, their longevity in the field.
Exactly. That's the other side of the coin.
So that's our mission today, to break down that choreography. We're going deep into those seemingly small details, a tiny bed height adjustment, making sure a cable isn't twisted, things that can prevent aspiration, or even, career-ending injuries for the staff.
We're basically looking at two main pillars, drawing from the source material. First, airway protection, which is all about keeping the patient safe. And second, ergonomics. That's about protecting the clinician, the person doing the procedure.
Makes sense. So before we dive into the how, let's quickly get the language straight. Especially for working as a team, what are the core terms we need?
Right, the body compass, basically. There are three main ones you'll hear constantly. Supine.
Flat on the back,
Yep. Then prone.
flat on the stomach.
Correct. And the most common for these procedures, left lateral or right lateral. Just means lying on that side.
Okay, so speaking of lateral, let's talk EGDs, esophagogastroduodenoscopy. Why is left lateral almost always the starting position? It seems minor, but what big risk does it tackle?
It really boils down to aspiration. When a patient gets sedation, even light sedation, their natural reflexes like coughing or swallowing properly, they get suppressed, they quiet down.
Okay.
So if you place them left lateral, you're using gravity. If any saliva or maybe stomach fluid comes up, that position helps it drain out of the mouth, away from the airway, away from the lungs. It dramatically lowers the aspiration risk.
So we're basically using gravity to keep the airway clear. Smart. But the source mentioned another benefit too, something for the operator.
Oh, absolutely. From a purely technical view, left lateral gives the endoscopist a friendlier angle to work with. It makes steering the scope, especially going down the esophagus and into the stomach, smoother, less pushing against tissue.
Easier navigation. Got
Yeah.
it. So once they're in that left lateral position, what's next? Those little pre-procedure steps, the tech handles, the small things that manage any remaining risk.
Right. Since we know fluid management is key because of the aspiration risk, the prep focuses on that. You need a towel, usually placed under the patient's left cheek and shoulder area, to catch any drainage.
Makes sense.
Then suction. It has to be on, has to be right there at the head of the bed, ready instantly. No fumbling for it.
Critical. And the bite block.
Yes, the bite block goes in, protects the patient's teeth, obviously, but also protects the very expensive scope from getting bitten.
Good point. And there's one thing that seems simple, but is crucial for breathing: the alignment.
Absolutely non-negotiable. The head and neck have to stay aligned with the spine. If there's a kink, maybe from a pillow bunched up wrong, it can narrow the airway. Even a small misalignment.
And then you might need to intervene manually, like with a jaw thrust.
Exactly. So your job as the tech is to make sure that airway pathway is straight and open. No pinks.
Okay, patient safety covered for now.
Mm-hmm.
Let's pivot to the people doing the work. Ergonomics. This isn't just about avoiding a sore back after a shift, is it? It's about making sure you can have a long career in this field.
That's precisely it. Endoscopy is physically demanding. You're standing for hours doing very fine, repetitive movements with your hands and wrists. Ergonomics is essentially designing the workspace, the tools, the setup to fit you, the worker. It's how you prevent those small strains from adding up over years into a serious injury.
And the absolute cornerstone of ergonomic setup, according to the source, is the bed height, governed by the famous 90-degree rule. And critically, you set the height based on the operator's elbow, not the patient.
That's the key insight. The target is for the endoscopist's working elbow, the one manipulating the scope controls, to be bent at roughly 90 degrees. The video suggests this usually means a bed height somewhere between 85 and 120 centimeters off the floor.
85 to 120 centimeters. And if you, as the tech setting up, miss that target, even by just a little bit. What's the impact over, say, 10 years?
It's significant. If the bed's too low, the operator has to constantly lean forward, hunching over. That puts a continuous load on their lower back, their lumbar spine, leads straight to chronic low back pain.
Okay, that's too low. What about too high?
Too high, and they have to raise their shoulders, tense up their neck and shoulder muscles, the traps. That causes neck pain, shoulder impingement, all sorts of trouble up top. Staying in that 90-degree sweet spot prevents all that wear and tear.
Right, small adjustment, big difference over time.
Yeah.
Now let's talk screens. Monitor placement. Dr. Raju calls it the tyranny of the screen, which I thought was interesting. It's easy to overlook, but crucial for neck health. How do you set it up right?
The monitor absolutely has to be placed directly in front of the endoscopist. No twisting the neck sideways. And the height is just as important. The top edge of the screen needs to be at eye level, or maybe just slightly below it.
So looking straight ahead, basically.
Exactly. The measurement range given is typically between 93 and 162 centimeters for that top edge, depending on the operator's height and if they're sitting or standing.
Avoids that constant looking down or craning the neck up.
Precisely. We want a neutral neck posture. And this isn't a one-time setup thing either. The technician needs to be watching. If the endoscopist has to shift their body for a tricky part of the procedure, you need to offer to readjust that monitor angle immediately. Keep it aligned with their new line of sight.
Ah, so it's an ongoing adjustment. Good point. That attention to detail carries over to the scope and tower too, right? Little things that cut down on shoulder torque and hand fatigue.
Definitely. Let's start with the tower, the main unit. For a right-handed endoscopist, you generally place it slightly behind them and to their left. You just mirror that for a left-handed operator. But the really critical part is when you hand them the scope itself. It's all about the cord.
The universal cord. Dr. Raju really emphasized this. Why is even one twist or loop in that cord such a big deal?
Because every twist, every loop adds drag and torque. It adds this constant rotational force that the endoscopist has to physically fight against while they're trying to do delicate work inside the patient.
So they're fighting the cord as well as navigating.
Exactly. It's this unnecessary background resistance over hours, days, years that puts significant strain on their wrists, their elbow, even their shoulder, the rotator cuff. So handing over the scope with a perfectly straight, untwisted, loop-free cord, that's a direct way you, the tech, prevent injury.
Amazing how something so simple matters so much.
Yeah.
And speaking of simple things, there was a mention of a washcloth.
Yeah, another small but effective trick. Placing a folded washcloth under the operator's hand where they grip the scope control section can really improve comfort and reduce muscle fatigue in their hand and forearm over a long day. Just a little bit of padding.
Nice. Okay, one last positioning detail for ergonomics, where the patient is on the bed itself, near the edge.
Yes. This is what the source calls the crucial edge. The patient needs to be positioned close to the side of the bed where the endoscopist will be standing, not smack in the middle.
Why not the middle? Seems like it would be standard.
Because if the patient is centered, it forces the operator to lean forward and reach across the bed to work. And that reaching, that forward lean, is a major source of back and shoulder strain. Keeping the patient close minimizes that reach.
Got it. Keep them close to the action. Okay, let's shift gears slightly to room flow and getting the patient onto the table safely. How does the setup differ generally between an EGD and a colonoscopy coming in?
The typical flow is that EGD patients usually enter the room headfirst on the stretcher. Colonoscopy patients tend to come in feet first.
Okay, entry direction differs, but the positioning goals are similar.
Mostly, yes. For both, you're generally aiming for that left lateral position once they're on the table, and you need to adjust the bed height and monitor ergonomically, just like we discussed. The patient's proximity to the edge, though, that can vary.
Ah, so the crucial edge thing isn't universal for colonoscopy.
That's right. It's a point where you absolutely need to communicate. For EGD, they're almost always right near the edge. But for colonoscopy, some endoscopists prefer the patient slightly more centered, others want them right at the edge. There's no single rule.
So the key is?
Ask. Always ask the endoscopist their preference for edge positioning before you start draping for a colonoscopy.
Good tip. Communication is key. Now, thinking about overall safety, sometimes the riskiest moments aren't during the scoping itself, but during the patient transfer, moving them from stretcher to table or back.
Absolutely. Transfers need to be treated like mini procedures in themselves. They require planning and careful execution. Before anyone moves the patient an inch, what's the absolute first thing you must do?
Lock the wheels, stretcher wheels, table wheels, everything locked down tight.
Mandatory step one. A rolling bed during a transfer is a disaster waiting to happen. Okay, wheels locked. Now, if the patient is awake, alert, mobile.
Guide them with 2 people, generally.
Right. But if the patient is sedated, groggy, or completely immobile, the sources are very clear on this. It's a team effort.
Yeah, you need more hands.
Definitely. Minimum of 4 helpers. And you absolutely must use an assistive device, a draw sheet or a rollerboard, not just trying to lift and shuffle them.
And it needs to be coordinated, right? Not just everyone grabbing on.
Totally. One person should be in charge of the count. Someone needs to specifically support the head and neck. Someone else, the legs. You have to watch all the lines, IVs, oxygen. And then move smoothly, slowly together on a clear count. Ready? 1, 2, 3, slide.
Smooth, slow, safe. Prevents patient falls, prevents lines getting pulled, prevents staff from hurting their backs.
Exactly. It's a high-risk moment that needs that level of attention.
Okay, so let's try to pull all this together for our listener, the tech or nurse learning this. If we synthesize this whole choreography, it sounds like the room itself, the way it's set up, isn't just background. It's almost like the primary instrument.
That's a perfect way to put it. The room is the instrument. And every tiny choice you make, setting the bed height to that exact centimeter range, making absolutely sure that cord has 0 twists, placing that towel just right. Each choice is part of tuning that instrument. It's the difference between a potential problem like aspiration or a staff injury down the line and just calm, safe, efficient patient care. The setup is the safety.
What's really cool is how this connects outside the procedure room. The source material draws this great analogy. The principles protecting the endoscopist. They're the same ones you use elsewhere.
Yeah, think about how you set up your own desk at home, maybe for studying or even gaming. You adjust your chair, right? So your elbows are bent around 90 degrees to stop your wrists from aching. And you put your computer monitor straight ahead, top edge near eye level, so you don't get neck pain after an hour. It's all about finding those neutral postures to reduce fatigue and strain. Same principles apply whether you're holding a scope or a mouse.
It's ergonomics for everyday life. Okay, let's quickly cement the key takeaways. 6 points you really need to have down cold.
Okay, number 1, left lateral position is your go-to for EGD. Protects the airway, helps scope navigation.
2,
Keep that head and neck aligned with the spine, always. And have your safety net ready. Towel under the cheek, suction on and close, bite block placed.
3, bed height. Set it for the operator's elbow. Aim for that 90-degree bend, usually 85 to 120 centimeters.
4, monitor. Directly in front, top edge at or just below eye level, typically 93 to 162 centimeters. And crucially, be ready to re-aim it if they move.
5, the peripherals. Tower goes back and left for right-handers. Hand over that scope with a straight loop-free cord and position the patient near the working edge, especially for EGDs.
And 6, transfers. Lock all the wheels first. Use enough people, minimum 4 for immobile patients. Use a draw sheet or rollerboard. Move smoothly on a clear count.
Perfect. 6 points to practice until they're second nature. So here's a final thought to leave you with, inspired by the source. If the principles that keep a sedated patient safe and prevent a career-ending injury for your colleague are the exact same principles you use to set up your home office, or even just help a friend stand up safely, what other invisible choreography is there in your daily work, or even your life, just waiting to be noticed and optimized for safety and efficiency? Think about that next time you walk into the suite.